We're going to talk about the consequences of delayed pediatric development. There's many different types of delayed pediatric development, and we're going to talk about the body's response to injury and the neurological systems. So this is, again, going to bring in that first week and even the second week of all of the importance of understanding really the brain and the lobes and the functioning of the brain. And then we're going to talk about, well, what happens if there's an issue that occurred either in the womb, during labor and delivery, and what we can do to help these pediatric patients. And our interventions are going to be much different than what they look like for an adult, right? It's all going to be centered around play, but a very focused play. And in our minds, we're going to be having things that we want to see accomplished, but we can't directly ask the patient, okay, go ahead and extend and push up on the ball. We got to make that baby want to go into extension and have some weight bearing through their arms. We'll talk about some different medical, surgical, and pharmacological interventions. These are really important to keep in mind because there's going to be some contraindications. If a baby has a shunt because of hydrocephalus, then we cannot be putting them in a head down position. If they have hypermobility, we got to be careful that we're not having them do any forward rolls because there could be negative consequences that occur. So really understanding the contraindications is extremely key for protecting our patients and educating them as well, and the parents. We'll talk about possible activity limitations, just as I said. We'll talk about specific interventions that we use. We're going to be using very different interventions for a child who has Down syndrome versus a child who has CP with hyperreflexia and hypertonicity. Okay, we'll talk about our environment and how that can play into the pediatric treatment and their development, and evidence-based practice. I do have a couple links for you. If there's anything else you want me to pull out of the PowerPoint for easier access, let me know. I can easily do that. And then identifying growth and developmental milestones. So what should they be able to do at a specific point, and recognizing, okay, if the child's barely crawling and they're a year, that's not typical. We want to see the baby doing what at 1 year? Walking, right? So this is why all of those developmental milestones are really key to understand what is typical and what is atypical. We're going to break out into breakout rooms here in a minute, but I just want to talk just a little bit of a lead in into cerebral palsy. Cerebral palsy in and of itself is not a progressive disease. There has been an event that has happened that has caused permanent damage in the brain. Okay, so you may be presented with a question that talks about progressive diseases, and which of the following is not. CP is not progressive. An event has occurred, there's damage, let's try to improve and get the patient to their highest level of functioning. Where an example of a progressive condition would be Parkinson's. We expect these patients to decline as their disease progresses in nature and they start to lose dopamine. With CP, there's been an event that has happened that has caused, maybe it's a stroke, okay, that has caused this permanent damage. Let's try to do whatever we can to regenerate that area of the brain and get this patient as typical as possible functioning, okay? It affects tone, posture, and movement. There's many different types of cerebral palsy presentations, just as there's many types of patients within the womb. Perinatal is weeks immediately before or after birth. There's been something that happens. We often see this with prematurity. Remember that in those last few weeks, the baby's brain is developing exponentially and it's highly vascularized. So if the baby is really born at a premature level and goes through the womb and goes through the birth canal, I should say, that trauma that could cause a stroke in the brain because that's highly vascularized at that point, okay, and very susceptible to injury. And then there's postnatal issues. Child abuse is a big one, TBI, near drowning. So the baby can have, and we'll talk about TBI specifically next week, the baby can have a trauma that is, so the traumatic event that has caused the cerebral palsy presentation is traumatic brain injury. So oftentimes you may see in a child's chart or an individual's chart that they've had a CVA that's resulted in cerebral palsy, or they may just have cerebral palsy due to CVA. Okay, so don't be surprised if you see those two together. One of them's the cause or the etiology, the other is the presentation. Okay, cerebral palsy is the presentation or kind of the umbrella term of this. The other thing that I was going to say is, even if you do not in your future think that you're going to be working with children, you may be working with an adult who has CP and they may be 35 years old now. Okay, so it's really important to understand the etiology, what has happened to this individual, and wow, they're 35 and they still want to be able to go to the gym, or they're having some trouble getting up the stairs to their college or something like that. So even if it's not in your goals to work with a child, you may just be presented with a case. I'm not sure if I shared with you, but I did work with a little child when I was an outpatient. We were closest to the patient's home. I talked to you guys about this, the child abuse case. The baby was developing typically, and the father got really upset because the child was crying and screaming. So at 15 months, the father smashed the baby's head on its dresser crib and fractured the baby's skull. And the baby presented now like it was 6 months old. And we were very close to the child's home. So that's why the mom decided to bring the baby to our facility. Even though it was outpatient sports based, we were closest, and she didn't feel comfortable having us go to her, having physical therapy go to her home. So there's many different circumstances that can occur. So that's why when you are educated and participating in education, why we try to have a really well-rounded curriculum, because you just never know who is going to come into your clinic and why, even if it may be very sports based or sports focused, and maybe you think they would benefit from having somebody who works specifically with that every single day. However, because we didn't work with that every day, we were all like really into treating this individual. It just very sad situation. Anyway, moving forward, all of these types of presentations can very much vary in presentation based on where the damage was in the brain and what the exact cause was. Patients can present with hemiplegia, triplegia, quadriplegia. So it really depends on what was affected, and it can change the different presentation and tone. Now, children who have CP often have other issues that go along with having these tonal issues. Many times there's a cognitive impairment, which is typical with a brain injury. Many times there's seizures, and sometimes seizures are unknown etiology of why they are occurring. Hearing, visual, speech, obviously, because of the different areas of the brain affected, and then sensory deficits. And we'll talk about a whole slew of different types of sensory disorders that are often presenting in isolation and sometimes with other diagnoses that we're going to talk about today. And then also other disorders can be coupled with this as well. So oftentimes this is not unidisciplinary, it's many times multidisciplinary approaches. We may be doing many co-treatments, PT, OT. So these are the different types of characteristics, of tonal characteristics. And so when we break it into our breakout rooms, we'll have a group that has hypertonicity. You're going to form a patient case scenario, one with hypotonicity, and then we'll have an ataxic group. Okay. Now, if you want, you can call me in your room if you're overwhelmed or have any questions on that. But the same type of presentation or interventions, they should say, that you used for your patients who have CVA is what you're going to be doing here with these patients. Think about what you did for patients who are hypertonic versus hypotonic. You're going to actually create a patient case scenario, build it so that it can be memorable for you, so that you can help link and remember these types of patient cases and scenarios and what this patient may present, okay? All right, so what we want to do is we're going to talk through our patient cases. On the spectrum of muscle tone, I first want to just, what you want to do is think about muscle tone in categories and who fits under it, okay? So muscle tone, we have, for just right now, what we're thinking about, we have high tone, we have low tone, and I want you thinking no tone, okay? Let me no tone. This also means flaccid, okay? So high tone is going to be our categories of that hypertonicity. Okay. Low tone is going to be hypotonicity. We're also going to be thinking about patients here with a low tone is patients who have Down syndrome. So it may say CP with hypotonicity or down patients who have Down syndrome, okay? This is like their whole body is involved, all right? When it comes to no tone or flaccid, let me put this all over here. Because we have this is why I wanted to talk about this first. When we talk about spina bifida, this is like a spinal cord injury. So it's going to be at level, meaning that if the patient has an issue at, and this is only if it's a lower motor neuron lesion. Okay, let me make this bigger and then that'll help. So let's say that the patient has an L2 that's below that conus medullaris. This means that it's a lower motor neuron lesion. So L2 and below is flaccid. There's nothing there. It's floppy. They can't move it. Okay, no reflexes at all. Where the patients who have hypertonicity or Down syndrome, that's going to be like the whole body. All right. If the patient has spina bifida, but it's occurred at a higher level, let's say T10, this would mean it's a upper motor neuron lesion. So at T10 and below, okay, that will be high tone. They still can't move it themselves. They don't have volitional movement, okay, but below is going to present high tone. So when you're looking, let me just draw this for a second. When you're looking at the spinal cord for spina bifida, we got our spinal cord here, okay? If we are at T10, okay, so it's at that level, and below is going to have the hypertonicity. The upper extremities are not going to be involved at all. So they still have full functioning and they are totally typical at that area. Okay. If it's T or L2 down here, it's going to be flaccid, no tone at all at that level and below. Make sense? Okay. So it basically their spinal cord's cut. We'll get into this a little bit more, but I wanted to just briefly talk about this. When you're looking at tone, it's going to be, is it the whole body involved, or spina bifida is unique in that it's basically a spinal cord injury. But it depends on where in the spinal cord. Most typically, this is very typical of spina bifida to be a lower motor neuron lesion, where T10 being an upper motor neuron lesion is rare, but it can happen. So we need to always refer back to, okay, what level are they talking about? So we're going to start with our group that has hypotonicity. We'll get through maybe hypotonicity with CP and hypertonicity with CP, and then we'll just take a little break. Okay, so let's hear about your case group 1.
Our group had cerebral palsy and hypotonicity. The patient is a 2-year-old male with diagnosis of CP and hypotonia status post sleep apnea. The patient's parents were unaware of the patient's sleep apnea and was left untreated for 3 months after birth. The patient presents with absent ambulation attempts and prefers to be in a dependent prone position. Progression milestones for the 2-year-old have not been met and is flaccid. Yes, so our treatment approaches and considerations was positioning and providing them supports in order to prevent hyperextension and abnormal bone development, hip dysphagia and hyperextension at the elbows. We have to stimulate passive and also active movement to stimulate muscle output, and I'll go ahead and pass the baton to.
Okay, very good. So hypotonic, okay, they're low tone. I like that you guys talked about the hyperextension in knees and elbows. So what we need to do is try to stimulate this patient to move, because a lot of times with hypertonicity, the patient doesn't really want to move or have the motivation to move. But at the same time, we have to make sure it's safe movement. So really weight-bearing activities are great. Quadruped is obviously an excellent position. So let me come back to this. So that the children typically are floppy presentation. Most patients who have, probably the majority of patients who have cerebral palsy, I think it's upwards towards 75% are more hypertonic, but hypotonicity does exist, and the babies typically seem a little bit floppy, okay? So we'll want to be doing activities to try to improve their mobility and stability. Okay. All right, let's hear from group 2. Let's hear about our hypertonicity patient.
So patient's a 2-year-old who was diagnosed with cerebral palsy with hypotonia caused by abnormality or disruption in brain development. Patient presents high tone, stiff and tight muscles even to the touch. Patient is very thin due to excessive energy output. Can also develop asymmetrical symmetrical tonic neck reflex. And patient's speech is also impaired due to poor voluntary and oral motor control.
So for PT treatment, positioning, range of motion, and stretching prevent fracture, inhibitory technique to reduce tone, facilitate achievement of motor milestone with integration of strong reflexes, use gentle and rhythmic movement to encourage controlled movement out of synergy, promote active weight bearing with aligned limbs and trunk, to allow optimal independence in motor skills.
All right, very good. Excellent.
Some contraindications are just fractures of the spine and joints. It's like acquired immune deficiency syndrome, severe spinal scoliosis, and spinal disc herniation.
Excellent. So a lot of these patients who have CP often have osteoporosis along with this, are very high risk for contractures with hypertonicity. And these patients, really, we want to do a lot of preventative care if we're anticipating these issues that are going to occur, talking to the parents, because we only can do so much because we're with the patient for this amount of time versus how much amount of time in their daily life. It's a full-time job to manage a child and try to make sure that they're providing all of the support that the child needs. It's a lot. So trying to educate the parents and talking to them about getting assistance and things like that to help support them as well during this process. But yes, interventions, if the child has hypertonicity, we need those inhibitory type of brief interventions to try to calm them down. Gentle rhythmic movement, which is going to be different than our patients who have hypotonicity. We're going to want stimulatory movement. We want to get them kind of bouncing around. We want to stimulate that tone to kick on. Maybe we're doing some erratic movement too. Okay, and I will show you a video in just a little bit of a patient with Down syndrome who we're trying to stimulate. Weight bearing is always a really good functional activity for both patients who have hypertonicity and hypotonicity for alignment reasons, but also for bone stimulation. So I'm going to show you a little video here of this little girl. They're going to be talking a little bit in this, but I more want you just to watch the video, and I'll actually pull this out so you can watch it with the sound behind it on your own. But basically this little girl was born and they told her that her mother that she was never going to walk. One of my biggest pet peeves in healthcare. Never say never, we don't know. But this little girl had severe spastic cerebral palsy. They did what's called a dorsal rhizotomy and did some contracture release. A dorsal rhizotomy, basically they cut away some of the nerves to reduce the spasticity. And show you. Let me just make it big. This is Journey. And I want you to pay attention to the type of interventions that they're having her do during this treatment. I'm going to turn this off so I can't hear it. So Johns Hopkins Medical Center, and this is her mom saying that when she was born, she had a really hard labor and delivery and a really tough pregnancy as well. So when Journey was born, she was told that Journey was never going to walk. So Here she is. And then the physician was saying how she was a very severe case when they saw her extreme in spasticity. And he talks about doing the dorsal rhizotomy and some contracture release. Here's the PT working with her. And this physician saying, basically, this little girl worked really hard, and that's what you'll find with a lot of children. They work really hard. They want to move, and given the opportunity and right environment. Now, these are called standard wheelchairs. It helps with weight bearing, obviously, for positioning and posture, but obviously also for the bone stimulation. And look at her walking. She's even walking without an assistive device. She gets her up on the ball. Look at this active extension, and she's got really attractive toys that she enjoys here. Okay, so the trick is to try to entertain the child so that they don't really feel like they're working. They feel like they're playing, right? That's going to be the trick with working with patients who have pediatric difficulties. Here we got the body weight support system. And so offloading, we talked about this last mod. We're getting her to do some squats here. So really functional exercise that we talked about last mod, just in a different type of approach and a different type of environment that were extremely effective. So yes, she had surgery to help reduce the overactivity, but then it's really about you as a PTA. Can you apply the appropriate activities to capitalize now on functional mobility? A little girl that was told she was never going to walk, and here she is standing, doing puzzles, walking without a few feet without an assistive device, and who knows how she'll progress as an adult. Given a really great opportunity, my advice is never say never. We never know how patients are going to progress. Now, we saw quite a bit of different orthotics in there. What stood out to you in those videos? What were some take homes? Some things that you saw that you liked, or that you were wondering what it was? Anything?
I had, like you mentioned earlier, she was playing more than actual work. So I guess the PTA or the PT that was in the video, she was really creative in what she had the patient do or journey doing.
Exactly. Very good. Yeah. So trying to create an environment that's stimulating to the patient and not boring, right? None of us want to be bored anyway, but finding what is that child's interest, and how do you find that out? By really talking and building rapport with your patient and the parents. There's a little typo here, and I'm not quite sure what it is, so I'll fix that. Was anybody wondering why she had all that strapping around her waist? Yeah. There's some like wraps and things. What do you think that was for? There she is doing a puzzle. What do you think that wrap was for around her waist?
Stabilization, support.
Yeah, exactly. Stabilization, support. Yep, help stimulate the hips. And it depends on too how it was wrapped. Yeah, can help with weight bearing. Yeah, maybe for positioning, because she's in a little bit of a flexed posture at her hips. Depending on how things are wrapped, it actually can facilitate specific muscles. And you learn that when we did the kinesio tape. But that same thing can apply with these types of wraps. One way can be stimulatory, one way can be inhibitory. So it looked like she was wrapped in a way to externally rotate her hips and open up her into more extension. They did a lot with a platform table and weight bearing. Okay, so patients like Journey are really at a very high risk for contractures and for osteoporosis. So as much as we can get her into functional positions, the better. On top of that, did you see a lot of gross motor or fine motor, or both? Both, yeah, exactly. So working in all systems and working on big and little. So it's just as important for her to be able to stand and grab what she needs to grab, whether it's her toys. Here it's a puzzle. Look at her fingers. The spasticity doesn't just stop in her legs or her hips. It's all the way throughout her whole body. Trying to be functional is going to be really important. What I think I want to do is take a small break here, because orthotics is something that I want you to have a fresh brain on. So let's just take maybe a 10-minute break and we'll come back, okay? So let's get back to it here. So when it comes to orthotics, now I wanted to start with this so you remember this. Orthotics can be used for anyone, not just CP. We see orthotics being used for patients who have Down syndrome, spina bifida, patients who've had strokes, right? People just who have peripheral nerve disorders. When you're reading questions and it says that a patient has an HKAFO, which means that they have a knee, hip, ankle, foot orthotic, it just means that they have an orthotic. You can't just assume that it's for a CP or for specific patients, okay? That's just means that the patient needs a lot of support, okay? Patients who have spinal disorders, or let me back up, whenever anyone has an orthotic, the orthotic will help control the joint above. Right, so an AFO, remember we said it's for drop foot, but it can also help with what? Preventing record bottom, right? So with patients who have HKAFOs, they could have a spinal problem, spina bifida, and it could help these individuals, okay? So when you're taking an exam and there's an HKAFO question in there, it's probably not about the HKFO. You got to look at the other things that the question's telling you. Is there a tone issue? If it's flaccid, the only people who are individuals who are flaccid is somebody who has a spinal cord injury. Okay. All right. With that being said, make sure you remember that for the midterm. Okay. So orthotics, many patients though who have CP have hypertonicity and oftentimes really need orthotics to help to control their tone. But orthotics can start with just as simple as a foot insert, can just support the foot itself all the way up. Okay, you do not need to memorize these DAFOs, okay, dynamic foot orthotics. Just know that there's many kinds and many styles depending on what the individual needs. Especially for children are constantly growing. A lot of these children will get custom made type of AFOs or just ankle orthotics that will constantly need to be changed because they're constantly growing and changing. Okay, so if you see any red marks, we got to make sure that we're looking at that. Now, there's certain AFOs for record bottom or hyperextension. There's certain ones because if the individual has a crouched gait type of deformity, many types. And some of them are just for positioning in a wheelchair. A lot of them are meant for dynamic mobility, and then there's other ones just to prevent contractures. Okay, so that's my thing, my spiel on orthotics, that anyone can have an orthotic. There's many types of orthotics. Just make sure that you know that the orthotic itself can help control the joint above. And oftentimes when you're faced with questions, you have to look at all of the other parts and pieces of the question. Okay. Tonia, we have a group that's covering ataxic gait. When it comes to dystonia is basically the fluctuation of tone. So the patient may be hypotonic in one area and hypertonic in another area. They may have a fluctuation where they're writhing or twisting movements, which is called athetosis. Patients who have these type of movements typically are very thin because their body's constantly moving, very exhausting. Okay. Athetoid is very hard to treat, and these individuals it's usually pretty severe. It can be mild to severe, but usually it's pretty severe. And just trying to get these patients to have a good quality of life. There's constant movement, trying to protect their joints from dislocating, making sure that they have adequate nutritional intake. Just like Huntington's chorea, if any of you have heard of that, many of these patients are severely anorexic looking because they're constantly burning, their body's never at rest. It's constantly burning calories and their body just cannot catch up with that. So what we want to do is try to maintain midline, maybe support them with orthotics or positioning devices, try to do inhibitory calming type of activities, gentle rhythmic movement, very tough to treat. And it's a very rare condition. Okay, yes, ataxic, we're going to have this group talk to us about.
Okay, so what our group came up with is a patient is a 2-year-old female diagnosed with ataxic CP due to damage in the cerebellum during birth. Patient presents poor balance and visual tracking, tremors, low postural tone, muscle are soft, doughy to feel to touch, hyporeflexia, wide basal support, and high guard arm position during gait. So what we thought of for a precaution is like if they have they may have a dislocation or subluxation of hip, head, neck control, or a communication difficulty. And for the PT treatment, we encourage midline, symmetrical posture for function, provide stimulatory sensory input for increasing orientation and increased proprioceptive feedback.
Excellent job, excellent job. Here, repetitive that we try to encourage that midline. I'm glad that you guys said it's a cerebellar issue. And oftentimes these patients who have ataxic issues are hypotonic. Group 1 and group 3, it could be linked together. Going back to our whiteboard, which I'll try to add later, when you're looking at these type of patients who have ataxia, ataxic gait is a very wide, unsteady gait. Okay, patients are typically fearful of moving and fearful of falling. It's an uncoordinated, wide base of support. Where patients who have hypertonicity, that's a lot of tone and it's drawing the patient in, and we often call that scissoring gait. So their legs are crossing each other and it's a very narrow type of a gait, and so very different looking type of gait patterns. Okay. Trisomy, any questions on cerebral palsy? Okay, so again, think of it as a group of disorders with various presentations. It's a non-progressive condition. Okay. Now, Down syndrome is also known as trisomy 21. Make sure that you know this for the quizzes and exams coming up. So go ahead, group 4.
Okay, our patient is a 6-month-old male diagnosed with Down syndrome trisomy 21. This means that the child is born with an extra copy of chromosome 21. Past medical history reveals congenital heart disease and scoliosis. The reports also show that the mother was 49 years old at the time of birth. The patient presents with muscle hypotonia, joint hyperextensibility, and transverse palmar crease or simian crease. Facial features present a flattened nasal bridge, almond eye shape, and flat occiput.
So for the physical therapy specific considerations, as Dr. Kiefer both mentioned, muscle hypotonia or low tone for individuals with Down syndrome, thus indicating like stimulation and gross muscle activity, just to go ahead and get everything facilitated, especially for the pediatric developmental sequences, So a lot of that will have to have some specific means to assess and coordinate like positioning or weight bearing activities. But the thing with weight bearing activities is that because of all the hypermobility and like scoliosis tendencies and other stuff, that sort of lends itself to a lot of contraindications and precautions.
All right, so patients with Down syndrome, they might have possible unstable atlantoaxial joint, and it's best to avoid joint compression, avoid extreme neck flexion, extension, and rotation, and also inverted positions, and then no forward rolling.
Excellent job. Yes, great job. And why don't we want to do this? Because we don't want to have dislocation. Now, if you're working with a patient who has hypotonia in Down syndrome, and all of a sudden you start seeing upper motor neuron issue or presentation, they have a positive Babinski sign, or their gait changes, or all of a sudden they have increased tone when they're not supposed to have increased tone, these are all signs that their spinal cord or their brain is getting involved. That is a medical emergency. Do not stop and talk to a therapist, press 911 and get that patient to the hospital. Okay, this is definitely could be on one of your board questions. This is definitely a medical emergency. But with that being said, with these patients who have Down syndrome or have hypotonia, these individuals, we really do need to get them weight bearing and get them strong. We need to turn on these muscles. So I'm going to show you a couple videos and then you can watch the other videos on your own. But these are examples of classic treatment that we would do with patients who have Down syndrome. So getting them on a ball. Okay, it's an unstable surface. She's bouncing him a little bit, letting him have something in his hand. Oh, let's give you something attractive to reach for. He's getting some weight bearing here. She's supporting him, helping him with the weight shifting. And then she's bouncing him side to side. This is not rhythmic bouncing. This is actually irregular bouncing because she's trying to turn on his muscles. Rhythmic bounces is calm. That's going to make a baby who doesn't really want to move probably fall asleep. We want to do more calming rhythmic activity with the patient who has spasticity, but for the patients who have hypotonicity, we want to do erratic bouncing. We want to stimulate their muscles as they're going to reach for something. Okay, so that's one example of a nice treatment. Here's another cage type of exercise. This just gives you a glimpse into some different types of strengthening alternatives for a child so this is our classic type of strengthening, right? This doesn't look very exciting for the patient. It's probably not very fun, but maybe it's really needed for this individual. So maybe they're doing a little bit of this and including in some other fun stuff after this. These might be the prepping exercises before we get the patient into this, which would be really fun. So maybe they know that they have that to look forward to. So they'll put up with some of the elastic bands. Here we got a nice cage. She's getting pulled from all different directions, got her in a weight bearing position. Really great to turn on these extremities, having her weight shift. She's also on a foam. So lots of different ways to get muscles turning on. And I love quadruped and I love kneeling. Those are really great ways to get at the core, get stabilization. Now she's at a nice lunge, very functional positions, and she's being challenged by these electric cords or elastic cords, I should say, not electric. We don't want electric. And then they're working their way up to standing, right? Quadruped, very functional developmental positions. And then what is she doing? Her ankle sway, our ankle strategy, bringing it back from last mod, right? And then she's got a stagger stance, same thing, trying to turn on those neural pathways so that way balance can become subconscious and not such a conscious thing, single leg stance. So these are all things that we're so familiar with from last mod, but now it's just a little bit tight, a little bit different setup. And then there can be vestibular fun. So maybe some swinging and bouncing, and the child can really look forward to that bouncing session at the end, right? Really nice, functional, and just a little bit of a different approach. Okay. Any questions on patients who have Down syndrome? Okay. All right, so the big thing with that, make sure that you're understanding what is Down syndrome. It's that extra copy of the 21 chromosome. That's why it's called trisomy 21. Make sure you know that because we're going to talk about a different chromosomal issue later. Okay, it's not super common, but somewhat common. Okay, all right, great job. That group, I can't remember now, group 4, I think it was. All right, our next group has a patient who has spina bifida. So let's talk a little bit about spina bifida and what it is.
So our patient is a 1-month-old infant diagnosed with a type 3, I could never say the word properly, myelomeningocele spina bifida, which is a protrusion of the meninges, cerebral spinal fluid, and spinal cord extending to the defect in the vertebrae located in L5. Due to nutritional deficiencies, especially folic acid from the mother, as well as environmental factors due to the mother drinking alcohol during the first week of pregnancy. The patient showed signs of lower motor neuron lesions because the defect is located on the L5. So these are like bowel and bladder incontinence, low tone, cleft palate, club feet, abnormal bone growth, flaccidity, and absence of cutaneous reflexes. And because it is a type 3 one, which is a severe one, patient might also present hydrocephalus. For intervention, usually if they have an open spina bifida, they tend to do a surgery first to close that area to prevent it from getting any worse. And as they get older, you want to minimize the deformities and fractures, and you want to make sure that they're properly handled and showing the proper techniques using ATLs as they get older. And you want to promote more motor milestones so that they can be able to, at least if it's not that severe, be able to walk, physically do certain things. And of course, once again, teaching them how to use ADLs to maximize their own mobility. And then for precautions, anything that precaution and contraindications for those with spina bifida, anything that can, injure that area or irritate it. And also because they might have hydrocephalus, the doctors will put a shunt in the brain. And you want to make sure that you're looking out for them having headaches, constant headaches, change in coordination, change in balance, and bulging eyeballs, stuff like that. Those are what we have.
Excellent job. Very good, very thorough. Spina bifida is quite complex because it depends on, you have to look at a few things. Where exactly is that spinal cord damage and to what extent is it damaged? Myelomeningocele is the worst levels, the level 3. So where there's that herniation. Now, we're going to talk even more next week with cerebral spinal fluid, but we have cerebral spinal fluid all surrounding our spinal cord and our brain. It is being produced at the same rate, or should be, as it's being absorbed. This helps to give cushion to the brain. It helps to clear debris, prevent infection. There's a lot of really great benefits to cerebral spinal fluid. But if there's damage to the flow, that can cause pressure within the brain. It can cause a lot of issues. If we know that a patient has had bifida or has had brain trauma, this is something that we are going to want to watch out for, is watching for signs and symptoms that they have a cerebrospinal fluid hydrocephalus, so pressure on the brain, because there's really not anywhere for it to go. That can cause brain damage. When this is caught and there's a certain pressure that should be within the cerebrospinal fluid, they can do a spinal tap and check this flow. Okay. If the flow, there's an imbalance, they can place a shunt within the brain, and that shunt can be controlled, but the shunt can also malfunction. So even if a patient has a shunt, we can't just think we're in the clear. We still have to watch out for signs and symptoms of syphilis. We also want to make sure that if you're working with any child or anyone who's had brain trauma, we want to ask if they have a shunt. Just like a pacemaker, we can't assume it's in the chart, even though it should be, and it should be at the top of the chart, but make sure that you are checking on that, because we do not want to be putting the child in any compromising positions that could negatively impact the shunt. Okay. Again, the shunt placement really helps to facilitate that flow, make sure that we are having nice homeostasis. But signs of shunt malfunction or intracranial pressure are all of the things that you listed within your pre-class assignment. Really great job for all of you. Now, the other thing to take note with this spina bifida, so this patient case, it was an L5 spina bifida was occurring. So this is a lower motor neuron lesion. Okay. Let's say that the patient, I'm going to type here, the patient has a T10 level spina bifida. Okay. So what we have to think about is the patient's going to have an upper motor neuron lesion. So what that means is, are they going to be hyper or hypotonic presentation? Hyper, very good. Hypertonic. They're going to be hypertonic at the level of T10 and below. All right. Making sure that you're understanding that the upper extremities work just fine, and they actually develop so that in this picture here, this young lady who's got Lobstrand crutches, she's very typically developed in her upper body. Her lower extremities don't look, it might be just the view of the picture, but I don't think so. It doesn't look like they have developed very typically. However, if that spine bifida has occurred at L5, she's still got her hip flexors, right? This is why it's really important to understand your levels of spinal cord. And we're going to jump into that a little bit more, obviously, when we get into spinal cord week, which is after the midterm. But this is a preview of how in depth we need to get eventually, is understanding what exactly is working at what level, because just because they have spina bifida, it doesn't mean they're non-ambulatory. We can most definitely have a patient be ambulatory. Maybe it's not the entire spinal cords involved, depending on the level of the spina bifida. Okay, so I know the reason why never say never, but we do have to keep some things in mind. Weight bearing is really important, whether the person's going to be ambulatory or not. If we can get them in a weight bearing position, that's going to be really important for them for so many reasons: scoliosis prevention and obviously osteoporosis. But we also want to get these people moving, because the more weight that they're carrying with a spinal cord injury, the more difficult it's going to be for them to move. Okay, a hard conversation to have with some patients, but it's something that we need to do. All right, we have two more cases. We have muscular dystrophy, which you have been exposed to muscular dystrophy since pathophysiology. The one that mostly we talk about is Duchenne's muscular dystrophy. Let's have our next group talk.
We had a 6-year-old that presents with Gowers sign, scoliosis, and muscle atrophy. She's known for frequent falling and toe walking. And then I'll let one of the other boys finish it off.
Yeah, so again, patient presents only in males. The mother is the silent carrier. Again, the patient's definitely going to show Gower sign beginning about age 6. Scoliosis is also present. Common is toe walking and frequent falls again. Through the etiology, what's being affected is a gene that encodes the protein for dystrophin, and low dystrophin in patients with Duchenne's muscular dystrophy leads to overall fiber damage and gradual progressive weakening of the muscles. PT treatment would be maintaining ranges of motion, stretching, splinting, positioning, constant ambulation, and standing skills as long as possible. Educate proper use of assisted devices. And also we're including pursed lip breathing techniques. Contraindications: no extreme or aggressive strengthening exercises. PT considerations would be preserving mobility in the patient. That's the overall goal, just the main thing we're working on. Help prevent osteoporosis. Definitely mental, psychological, emotional support. Sit-to-stand exercises will help maintain bone mineral density. Considerations would be also AFOs, KAFOs. We're constantly monitoring the respiratory functions to prevent, as we learned last month, tachycardia, which is the collapse of the lungs. And I would imagine that because the heart is a muscle, we want to do like aquatic therapy considerations, maybe as a low impact cardio for the patient, if that's acceptable.
Exactly, very good. So yeah, the whole goal is quality of life. So this is a link for, and I'll pull this out and I'll put it in your main week, so that you can pull this out and watch it. It's very sad. So this is the progression. You saw the baby was typically developing eight months old, rolling really easily. By 3, they have a hard time. They have that head lag. They have a hard time rolling over. And you saw at 6 years old, he started to have some spinal deformities. They have them in their underwear, so you can see their entire body, but you can see not really keeping up with their friends at 7 years old, 8 years old. Very difficult to sit up, very difficult, trying to use a lot of compensatory movement. That's the goer sign. So why are they doing that? That weakness of the abdominals. They're using their extremities to try to compensate. Okay. Have to roll over. Pretty tough to get up off the ground. Core weakness. He's going to walk his legs up, and then there's the classic goer sign. So he's using his arms and his legs because his core is not turning on. And look at the core so weak, he has to do a rotation, torsion type to sit up. I'm going to continue to have more difficulties. We got he's toe walking. Look at the gastrocs are pretty pronounced because he's overcompensating there. with the drop foot. Okay. And scoliosis presentation, off shifting, trying to lift the arms against gravity. He's barely a 3 out of 5 there. Now we got this other little boy, 11 years old, pretty much in a wheelchair now. Motorized so he can get around. So maybe your session would be to teach him how to use that safely, how to get in and out of it safely. Okay. Here he is, really hard, definitely not a 3 out of 5 strength, right? Yeah. Lots of compensatory movements, trying to use spinal extension, try to do it at the same time. No way, not happening. And look how exhausted he is, but he's got a good attitude, a little thumbs up there. Most of them get scoliosis. Surgery may be required because of pain, not because we think that the patient's going to become all of a sudden become very functional, but scoliosis can be quite painful. So they outweigh that. Sometimes then it becomes very difficult for them to bring their hand to their mouth. Now remember, not all patients who have Duchenne's muscular dystrophy are going to have cognitive impairments, but many of them do. Okay, he's got a harness on him to help keep him upright and keep him safely in the wheelchair, some head support there to help keep him erect. Biggest thing that causes individuals who have neurological issues to pass away is typically respiratory failure, respiratory compromise. So airway clearance, a lot of them will get breathing treatments, helping them have a productive cough. Sometimes we come in and we'll assist them to cough. Okay, BiPAP machines. And these little boys don't typically live past, it's in their 20s now. So very sad condition. What we need to do when we're working with individuals that it's a very difficult situation is try to keep a positive attitude, make therapy fun, may have it be their highlight of their day, try to really focus on what they can do, trying to get these individuals to have a good quality of life. Okay, how can we take away their pain and how can we help them? But really, again, making sure that there's no aggressive therapy at all. It's all supportive therapy. Question?
I as a parent, I don't imagine if they don't present symptoms till around 2 years old, is it mostly just a shock for the parent or is there some kind of test that?
Excellent question. So it depends on the parent. When people are pregnant, they can get testing done to see if the child has a chromosomal issue or any developmental issues. So sometimes this is known to the parent prior to the patient, prior to the baby being born. The next condition we'll talk about even more in depth about that, but some individuals, they either don't believe in the testing, don't know, but a lot of times the testing is done when the child is an infant. However, yeah, sometimes the baby is 2 or 3 years old and the parent brings them in and says, what's going on with my child? They're starting to fall a lot. And yeah, as a parent, it's just absolutely heartbreaking. And it's just a really horrible disease. And yeah, it's horrible from all aspects, right? Spinal muscle atrophy is now, so we talked about Down syndrome. Down syndrome is not something that we are carriers for. Down syndrome, there's specific things that have occurred. Typically with Down syndrome, it's older parents are at a higher risk. When it comes to spina bifida, it's a folic acid typically deficit. So there are reasons that certain things happen, but there's also people are carriers for many different disorders, okay? So I had my son a little bit later in life, so I decided to get tested to see what I was a carrier for. I'm a carrier for spinal muscle atrophy. My husband got tested as well, and he's a carrier for other scary things, but we're not both carriers for spinal muscle atrophy. So there's zero chance for my son to have spinal muscle atrophy. If my husband and I both were spinal muscle atrophy carriers, there's still only a 25% chance that the child would have spinal muscle atrophy. So there's a lot of different very scary disorders that you can get screened for. People who are in their late 30s and 40s who are having children oftentimes will get screened in order just to be aware. And then there's other testing that can happen. So let's say that my husband and I both were carriers. We could have had the child get tested in the womb, which is called neutral testing. They have to go through, and it's actually a little dangerous for the mom and the baby to get this tested, but they can test the baby to see if the baby has the abnormality, and then the parents can make a decision depending on obviously what state they're in of how they want to proceed. Okay, so there's it depends on the people who are having the child and what their belief systems are. For me, I wanted to know, and that's just it. Everybody's a carrier for something, but it depends, is the person that is your partner or donor or whatever, are they the person that also has this disorder, and then it increases your life. All right, let's talk about spinal muscle atrophy, and then we'll take a little break, and then we'll wrap things up. We don't have much more to go after this.
So patient presents with autosomal recessive genetic mutation on chromosome 5. This results in a progressive degeneration of the anterior horn cell. This is also the second most fatal autosomal recessive disorder. There are various onsets, type 1 being the most severe, type 3 being the most mild. As mentioned, it presents as a progressive muscle hypotonia, weakness, and atrophy.
This patient will present with progressive muscle hypotonia and weakness and atrophy in their muscles. They will have diminished they will have normal cognitive function and intact sensation. Usually their death is due by respiratory dysfunctions. Considering all of that, treatment is primarily supportive and preventative, especially towards the pulmonary infection side and any sort of orthopedic deformities like scoliosis. It's important that we make sure that we train the parents on proper positioning and creating access to play opportunities for children with SMA.
Excellent, very good. So yeah, these little munchkins have a really tough life ahead of them, and it's usually very short as well. It depends on the severity of how long they can live, but again, it's usually respiratory compromise that it leads to their death. And I think this picture here is what you really should think about when you're thinking about spinal muscle atrophy. The nerve is atrophying and retracting away from the muscle. So the muscle's not getting the input, okay? This is different than Duchenne's muscular dystrophy, where they are lacking the protein, and the muscle itself, the content is changing. It's turning into fat, okay? So that's the difference there. This is really the nerve signal is not going anymore. It's not reaching the muscle, where Duchenne's is just different in that way, okay? So again, you're going to see a lot of the similar type of interventions, orthotics, weight-bearing devices, okay? So it really, you're going to see a lot of consistency with approaches, because it really is trying to get the patient to be functional and in a functional position and try to reduce these negative effects, okay? Very sad stuff, right? But again, we have to try to train the parents, train the caregivers, try to make the treatment fun and as much fun as it can possibly be for these individuals, and be that bright spot, right? Now, these are a few of the disorders. These are the more common ones. There's many other horrible diseases out there, but a lot of rarity. But what you need to see, what you need to take home from all of this is you're going to try to focus in on quality of life. If there's hypertonia, we need to calm that hypertonia down. If it's hypotonia, we got to try to stimulate these patients, okay? And that's really the take home there, okay? Now, The last thing that I want to talk about, this isn't really the last thing, but the last main disorder is torticollis. So torticollis is a positional deformity, okay? We talked about this last month. So this can be that the baby's born with torticollis, or it could be that they acquired it. Either maybe they prefer a certain side of the mother for breastfeeding, which is extremely common. Maybe they just prefer to lay a certain way. So many of these babies, though, oftentimes have another diagnosis with this. But what it is basically dystonia, or a contraction of the sternocleidomastoid, okay? So the baby is going to be stuck in this side bended position, okay? So they're gonna be side bent, and then they're gonna be rotated and flexed, okay? So they just have contraction of the sternocleidomastoid. So you just have to think torticollis is an overactivity of one of the sides of the sternocleidomastoid. Okay, so when you're faced with treatments or questions about this, I'll come back to this position in a second. When we are faced with questions about this, it's going to ask either what is the position the baby's in, this side bent, flexed and rotated position, or what is the treatment? The treatment's going to be opposite. So what do you think? Contralateral what? Contralateral rotate, side bending, ipsilateral rotation, and then extension, because we're going to want to stretch that section of the sternocleidomastoid. Now, is it very typical or easy to stretch a child? Absolutely not. So this is tough. It's really tough. But what if we don't? What if we don't treat this? The baby's going to have a skewed look on life, right? And it can also change the shape of the head, which is even worse. So there's a lot of reasons that this can happen. Sometimes it can just happen. Maybe there's an injury that has occurred. Sometimes that can happen during labor and delivery. Sometimes there's tumors, which is more of a rare case. And maybe the baby just prefers a specific side, which is actually common. Okay, so impairments here. Facial, if it's not addressed, the baby's going to have asymmetry of their head, which includes their face. It could cause scoliosis all the way down their spine. It can create developmental delays. If they're only looking into one side, they could have one-sided neglect. So it's really important to try to catch this as soon as possible to treat it. Okay, so we're always bringing the baby back to midline and trying to promote that stretch. And here's some exercises. So I love this little guy. It's so cute. So here, and we'll take a little break after this. So here's an active treatment with the child, trying to give them, okay, depress that scapula, depress that shoulder, depress that clavicle, and have a little bit of lengthening here. And she's getting the body weight to go over top to give a little bit more of a stretch, okay? And they probably have some sort of visual in front of him, not just the camera, to try to get his eyes to focus in on something. Change it up. Don't just keep doing the same thing over and over, because the baby's not going to like it. So symmetrical flexion, and she's probably saying some cute things to him to make him really entertained. Cross the body and open up wide, and then she can go back to doing some of that rotation. Okay. We can also use bean bags for positioning, which is really nice. Here's another active treatment. Can a baby overcome this disorder? Yes, absolutely. So they definitely, it's very treatable, but the earlier the better. So a lot of times parents it might not be picked up on by parents who don't have any type of background in this. And sometimes it can be missed by physicians because the baby's only in there for a short amount of time. And sometimes the physician's looking at other things. Trying to have a really nice dynamic type of activity, get the baby in quadruped, but look at, they got a bias to the one area. They're side bending this way actually. So I'm gonna come out of that, but you can watch that treatment. The other thing is trying to promote extension, right, rather than flexion. So maybe some visual reference. Here's another manual stretch. Getting the baby up over a roll or bean bags are really nice. And then here's an example of a manual stretch. So trying to give a hug. And then babies like to be sometimes carried in this kind of sling position. So the father can bring the baby up into the side bending position, but it's very high frequency of doing this stretch, very high, and trying to position as much as possible in that center position in that midline. Just as I said with doing the prone prop and getting the baby into the belly time diaper changes, because you're doing so many diapers when they're little, these are a great opportunity. Okay, a reminder to go through that activity at that point. The problem though, if this isn't addressed, those symmetric, that head becomes asymmetrical. This is called plagiocephaly. And the problem with this is that the baby's head becomes deformed. It can change the shape of their face. It becomes flattened. And a lot of parents don't want their babies to have these little helmets, but their head is so mobile at this point, the earlier the better. So if a baby is 3 months old and gets this, they might even be wearing it for only 6 weeks, where if it later on at 10 months, now they're getting it on, they might be wearing it for 6 months. So the earlier intervention, the better, and talking to these parents about the benefits of it. And it really will help with development as the baby gets older. And these are typically changed every single week. They have to wear them 23 hours a day. It sucks. It really does suck. But the sooner the better. The baby's not really sleeping at 3 months anyways. Just do it. Just do it. The earlier the better, because at 10 months, they should be having a really nice sleep and having consistency there. These are really nice foam. We do not do the molding or the changing of these. It's a specific person that's an orthotist that's doing these types of molding, but we may be communicating with them to say, hey, I think the baby's ready for an adjustment a little earlier or something like that. Very hot for the babies, but again, extremely effective. It can totally be recorrected, but the cause has to be treated. If it's torticollis, that's the cause, which is not always the case. The baby could have plagiocephaly without having torticollis. It may be just the way they're laying, but it has to be the root cause. If it's torticollis, has to be addressed first before they can go and put a corrective helmet on them. Okay, any questions on this? Okay, so the last thing, we're going to take a little break. We're going to talk about some sensory disorders. I'm going to go through them very quickly because they are usually coupled with something else, but I do want to have us discuss some of the different types of treatment. We're going to talk about epilepsy and then finish up with some foot ankle deformities that is really important for us to discuss, and then we'll finish up. So let's just take, are you guys okay with doing like a 5-minute break? Let's get back to what we want to talk about here. So the last section of this, we're going to talk about some sensory disorders. So we talked quite a bit about sensory integration and balance, but this also plays into just learning, attention, behavioral abilities, how we get all of this information that's coming in, whether it's somatosensory, visual, vestibular, how it comes in and how we process it, right? But for children, and children grow up to be adults, so adults can have these disorders too. These are where in the brain, there's processing issues, okay? Some people can be over-responsive, under-responsive. Maybe they're seeking out sensory stimuli. There's a lot of disorders. I'm not going to focus in on just one. When you're working with an individual, you may see that they have certain disorder and just becoming very familiar with what does that mean and trying not to trigger it and trying to respect it. So if somebody, for instance, when I did like a little rotation for a week in a school, I saw a little 4-year-old who was scared to climb their little foam playpen because her body was too scared of that stimulation of climbing. It was just too much for her. So the therapist had to really work with her on trying to overcome this fear because her body was way too heightened to be able to play on a play set, which is really sad. And then you have these other individuals who can't get enough of it and they want to climb to the very top and then swing off the roof, right? So we have these two spectrums, and how are we going to satisfy these sensory needs and try to calm them down to process properly. So I'm going to let you watch a lot of these on your own, but I think some of these are actually really cool type of setup integration. So trying to really stimulate all types of systems, challenge the individuals, working together as a team can help individuals really with communication skills and being able to work with others, because a lot of kids feel isolated or don't know how to work with others. So if there's an obstacle course that they need to work together with, can really help with that. Timing, coordination. So there's some of these really rad type of setups. You saw the rock climbing wall in the background. They have some of them where, okay, you have to climb to the very top and then complete your math assignment. Okay, so then they have this gravitational pull, but helps with focusing, lots of different types of stimulation, vertical spaces, maybe helping with development. So really pretty cool stuff. All team, yeah, that's funny. Yeah, so she's really cool activities, stimulating their vestibular system with swings, okay, and trying to help them maybe overcome their fear or satisfy that sense of stimulation so that they can focus on other things. Okay, so that's just one form, and then sensory processing. You know what, this one's 9 minutes, so I'm actually going to let you watch that on your own. We are not doing a group activity today on this. Sensory over response is exactly what it says. The hypersensitive, very irritable type of children may fight because they're frightened. Okay, so understanding what is going on here, they might run away, they might flee. So understanding why a patient might have a reaction, and many school systems are set up to handle this. But it can be quite exhausting as the treating therapist or anybody working with the individual, and parents as well. Sensory under responsive, these are the kids who are really they present kind of clumsy, they lack initiative, they're just whatever. And oftentimes this sometimes can go with the hypotonic type of presentation. The individual really needs a lot of to get them moving. Sensory seeking, these are the individuals that exactly need that. They need to swing, they need to climb, they need all of the stimulation to really help them. And then sensory discrimination, so having a hard time with discrimination. So they might be really frustrated with themselves or just in general. They have a hard time with motor planning. These are the patients that really need a lot of patience and helping them to become patient with themselves. This is why we don't work alone with patients. A lot of times we're working maybe with their psychotherapists, occupational therapists, maybe even speech therapists. It's typically a multidisciplinary approach. There may be other individuals that have defensiveness, and just being aware of this. Some individuals do not like their hair cut, touched, combed. Some individuals don't even like to be touched. Understanding this so that we can approach them appropriately. This is why reading charts is really important. And then postural defensiveness, fears of movement. So a child might cry. That's not really typical for a little kid to be afraid of jumping or going on a seesaw. If we see these things, that's not typical, and we may need to speak up like this. You may need to have them go back to the physician to get further evaluated, etc., because early intervention is the best intervention. Okay, and then some other things. If we know some things are triggers, loud noises, then maybe we try to make sure that we separate ourselves, or if there's a certain time of day when music is played in a certain area of the school, maybe you're doing your therapy session in a different area of the school. Okay, and then other sensory behavior in general, do not wear cologne or perfume. Okay, this can be irritating to anybody, just something to keep in mind. I see that with a lot of adults, that they just do not tolerate smells. Okay, and then sensory processing. So there's a lot of different types of techniques. Maybe it's fine motor sensory, maybe it's gross motor sensory. Lots of different really cool things. This one is another one that's really wacky and out there. This was created by wow, look at that sensory seeker. I would be probably vomiting my brains out. And then having them jump, having them go across different types of getting all the systems working together. This one I like, they're using the mouth, helping them close their mouth. That's a lot of these individuals will have swallowing issues or speech issues. And then again, working through teamwork can really help these kids not feel alone, sense of accomplishment, things like that. Okay. We'll skip ahead here. Sometimes working with, I saw one of the groups and they talked about it a little bit, having the weighted vest. So sometimes weight can actually really help an individual who has fear feel safe. We've all heard of weighted vests for dogs and animals with thunderstorms. The same thing works for children and even adults. So really being very creative and total body strengthening. Wow, 50-pound ball, getting his whole body involved. And again, working with maybe music and different textures, lots and lots of planning that goes involved there, goes into that. Now, autism is something different. So all of those types of sensory type of disorganization conditions can be part of autism. Autism can be part of cerebral palsy. So you may see a lot of these diagnoses in isolation or together. Autism, though, is a spectrum, and the big thing is for the individual to have some sort of diagnosis so that they can receive the early intervention. Early intervention can really help have a typical life. So there's a woman that I've treated for quite some time, and her son has autism. He was born and did not talk until he was 4 years old. He didn't walk until he was 3. He had quite a bit of deformity in his feet, and now little boy is 14 and just sang a solo at Santa Monica Junior High School, or whatever you call it, middle school. So it just goes to show she fought for him so hard to get the interventions. He's still getting interventions, and if you saw him, you wouldn't know that he has autism or on the spectrum. So it's really pretty cool, the interventions that can be done and can really help these individuals have a very typical life. There are still obviously some things that are occurring, and he's still working on them, but there's quite a bit that can be done. Communication is often frustrating for parents and for the individual. They aren't always able to exactly say how they feel and communicate that way. Sometimes the lack of eye contact and lack of communication is a big part of it. The big take home from autism is know that this is an extremely wide spectrum from mild to severe, and it's not our place to put someone on a spectrum, but to be understanding and respect it and try to work as much as we can to help them with having a typical life. Now, risk factors, it's still up in the air. A lot of people say vaccinations. That has been proven not to be the case, but there's still some people who fight that is the case. Premature births can contribute to it. I've seen another study that was published, the closer you live to a freeway or a highway can increase your risk. It's more common in men than women and in older parents. And again, it usually start to see some symptoms around 2 to 3 years old. And again, a multidisciplinary approach here. Okay, any questions on autism or any of the cognitive, sensory? Pretty straightforward. Now, epilepsy is something that is a disorder of seizures. Now, if somebody has a seizure one time, it doesn't mean that they have epilepsy. Epilepsy means there's recurrent seizures that are occurring. A lot of times there's an unknown cause, but oftentimes there's a central nervous system disorder that has happened, either a brain injury or maybe that the person has cerebral palsy. There's been some sort of issue within the central nervous system that causes these electrical discharges and hyperactivity. Now, for you as a treating therapist, what you want to do is know your patient's triggers. If you see that the patient has epilepsy in their chart, you're going to want to ask that patient or their parents, is there a specific pattern or a trigger? Because if you see that the patient didn't eat breakfast that morning, or that there's a light flickering in the room, you better shut that off if they have a sensitivity to light or flickering. Some people who are really tired will end up having seizures if they have epilepsy, and emotions if they're really stressed about something. So we had an individual in one of our other cohorts that has epilepsy, and she said anytime that she gets really stressed and doesn't get sleep along with her stress, it's a trigger and she ends up having a seizure. There's a wide presentation, but there can be quite a bit of variation presentation, but oftentimes there's staring, there might be a loss of consciousness, stiffness of muscles. But if someone's having a seizure, you do not restrain them. You let their body do what it needs to do, but you probably want to place them on their side, because if they vomit, they could end up choking on their vomit and passing away. So again, do not restrain them, know their triggers, be aware of side effects of medication. Status epilepticus stars, this is probably on your quiz in midterm, that this is when this is a medical emergency, that the patient keeps having seizures and they're not regaining consciousness. So we need to call 911. Okay, if the patient has a seizure during therapy and they recover, we're probably not continuing therapy, but if they've recovered from it, we may not need to really call 911. We probably want to call the physician and see what the physician wants them to do. Do they want to send an ambulance, or do they want them to drive to the local ER or to their office? Okay, so that is, but if the person's not regaining consciousness, then we definitely need to be calling 911. Okay. That could be a question on the boards. Again, the boards is really focused in on safety. Are you going to have the right reaction to an emergency type of situation? All right, lastly, any questions on epilepsy? Anybody have or know anybody who has epilepsy? Kyle does.
Yeah, my mom has epilepsy.
Oh, your mom has it. Oh,
It's like a weird type. I don't know. They haven't really diagnosed her, but it's basically when she doesn't get a lot of sleep, that she tends to have like small seizures. Nothing crazy, but yeah, she's had it for 5 years.
oh wow, I'm sorry for her.
Oh, it's fine. She's fine.
Yeah, she's fine. She's fine. Easy for you to say. No. Yeah, but yeah, so yeah, a lot of times you can have really mild cases, and I hear that from quite a bit of people, that they only get it if they get stressed and they don't have a lot of sleep. But then you have other people who have really these grand mal seizures, and that's very scary and very dangerous. And someone could die with having a seizure. So that's why it's really important that they're being monitored by their physician, that they're taking all precautions to know their triggers and things like that to prevent them. Thank you for sharing, Kyle. Anyone else? Are people with epilepsy allowed to drive? Yeah, so that's the big thing. So it depends. Now, if the person has epilepsy, typically they cannot have a license. However, if they go a certain period of time without having a seizure, they can get their license back. So I know a girl who's had severe epilepsy since she was a child. She didn't get her license until she was 34 years old. They ended up doing like brain surgery, and she doesn't have any seizures anymore. So it was pretty amazing when she got her driver's license. She actually started with bicycling and was like, she didn't even bike until she was in her 20s. So it was pretty amazing to see her do things that you take for granted as just being a typically developing person. Yeah, 2 years without seizure. Thanks, Grace. Yeah, I didn't know how long it was. Yeah, it's pretty cool when people can start to get independence back and get their disorder under control. Medical advances are really amazing. The last thing that we're going to talk about are foot deformities. There's a lot of reasons for foot deformities. Oftentimes it's because there's a central nervous system disorder like CP that has happened that causes the individual to go into a spastic position. However, a patient or a child may have been positioned odd in the uterus and then end up having a deformity such as one of these three. You do need to know these for your midterm and your quiz that's coming up. When you look at the names, and then look at the picture, it makes sense. Metatarsus, so look at where the metatarsals are and they're pointing in, right? Explains it right there. Talpus equinovarus is also known as clubfoot. So the patient's plantar flexed and extremely inverted. So think about your sprained ankle position is clubfoot. Okay. Another way to remember this is equino or equine gait. That's toe walking gait. That's another word for that. So the patient might have to be in a plantar flex position in order to be in equinus position, have that is their gait description. Calcaneal valgus, again, this is described as the position, so it's the opposite of clubfoot. They're going to be in extreme dorsiflexion with eversion. They're going to have valgus of their hind foot, so it's going to point out into eversion. Okay, that L for out. So make sure that you're understanding those three. And then another thing that will be on your test is serial casting. So serial casting is an intervention. Basically, they stretch the foot out. So let's say that they're in that severe calcaneal valgus position. What they'll do for treatment is they'll stretch them and try to get them as far into plantar flexion or neutral position as possible, and they'll put a cast around them. So they'll be in the stretched position for maybe a week. They'll take it off and then they'll stretch them again, and then they'll put them in another serial cast so they can gradually get this prolonged stretch to help with the deformity. So serial casting is an intervention to help with foot deformities, and it's for stretching. Stretching can obviously be another intervention, and if they just have surgery. And then what we want to do is they're then in a cast for so long, they've been deprived of sensory input. So the baby may be hypersensitive to touch. So what we want to do is try to restore that sensory integration and stimulation again with all of these. So we're going to talk all about traumatic brain injury next week. We'll talk about mild traumatic brain injury, and we'll talk about concussions, which is a mild traumatic brain injury, and then we'll talk about the really severe type of injuries. I want you to watch the video on the Rancho scale so that you can get an idea of what these individuals who have brain injuries. So what did you learn today? Pediatric disorders are very sad. Yes, they're very sad and very scary. Makes you very grateful for what you have. If you have kids, or I don't want to work with peds. Yeah, exactly. So for me, I never wanted to work with peds. One, because I'm a crier. And I also think that there's, with the whole dynamic of it, as people age, you're expecting them to have accidents and incidences and decline. And it's hard. It's hard enough with older individuals, and being with peds, that it takes a really strong therapist to work with them. However, it's extremely rewarding. And how fun is it to be like playing with kids, right? Very good. So it's not 21 pairs, it's the 21st chromosome has an extra chromosome, okay? And what we call it is trisomy 21. It's the 21st chromosome that has an abnormality. Very good. No rheumatoid. CP, incomplete closure. Most of you got it. Good job. So there's those three levels. Make sure you look at them. Okay. Spina bifida occulta is that what was demonstrated in that picture. Meningoceles when it's all the way herniated. Good job. Everybody got it. Good job. Very good. Good job. Make sure that you know that definition. Good job. All of the above. All of the above. Because it's the spinal cord that would be involved at that level. C1, C2, that's an upper motor neuron lesion. Okay. We're with that occurring with patients who have rheumatoid arthritis and patients who have hypotonia. It results in anterior horns, because the anterior horn, remember, is the motor portion of the spinal cord. Always going back to what we talked about in those first few weeks. Great job. False, because it could happen in the lower thoracic region. So make sure you review this for the midterm and for the finals. Left torticollis, put yourself in that position. If they have left torticollis, the left SCM is contracted, okay? So they're in left side bend, right rotation and flexion, okay? It's contracted. So their treatment is gonna be the opposite. It's gonna be right side bending, left rotation, extension, okay? Make sure that you work through that, and then when you're reading the test question, is it the treatment that you're seeking, or is it just defining it? Plagiocephaly. Craniocephaly makes more sense to me, but it's plagiocephaly. Which lobe does sensory? Okay, so yep, parietal. So you got to think about, okay, the central sulcus, and make sure you can identify that for your midterm as well. What's in front is our premotor cortex. What's behind in the parietal lobes is our post gyrus. It's our sensory. Okay, parietal, you got to think sensory, frontal motor, temporal hearing, occipital vision. Excellent, very good. Yeah, we want to protect their body from injury. So if there's anything around them, we're going to move that out of the way. The reason this one's not correct is if they vomit, we actually need them on their side. Okay, good job. It's the opposite of flip foot. Good job. Remember, the Quine's type of gait is that toe walking gait. These patients are in plantar flexion and inversion. Great, because nobody with any of the same type of diagnoses really presents the same, right? Statistic mean A without X. No oxygen. Excellent job. Great.